All right. Hello, everybody, and welcome to AOCPMR's March Journal Club for the 2023-2024 academic year. I'm so happy to welcome you. I'm Nick Trevellis. I'm one of the research members. We are so honored to have Dr. Harmanjot Singh with us tonight. He is a PGY2 at Medical College of Wisconsin, and he is presenting on the article Interpreting Pain Symptoms and How Pain Affects Neuromuscular Control in Dancers. If I'm in pain, how should I train? Dr. Singh is a former dancer himself, and as a physiatry resident, his interests include pain, sports medicine, and general rehabilitation. Dr. Singh, thank you so much. Welcome. Take it away.
Thanks for the introduction. You guys can just call me Harman. So yeah, I'm a PGY2 at Medical College of Wisconsin. As he said, I am a former dancer, so I thought this article was pretty interesting, talking about kind of the past, current, and kind of the future research that's being done in kind of the neuromuscular aspects of dance. And that the stuff I'm going to be talking about today isn't just just for dancers. It can also be tied into any athletes or anyone in sports medicine. So I'll be referring a lot just kind of to my experience as a dancer, but also it can be reflected onto other areas of physical activity as well. So starting off, so I'm sure all of you guys have heard some variation of this phrase, just dance through it, or just play through it, tough it out, or just do it. This is a pretty powerful phrase. It's nice. 90% of dancers have suffered injuries that prevented them from dancing at some point in their careers, with low back pain and kind of any lower limb injury being the most common. So when you kind of hear this phrase, it definitely takes a psychological effect on the dancer. So the decision to train is always a tough one. The decision to continue training, to continue dancing, to move forward is always a tough one to interpret. And it's also indicative of kind of the high self-efficacy and resilience that dancers and athletes have. So this perception of pain that we all have can essentially reflect any actual or potential harm and damage to our bodies. And this pain perception can affect the ability to monitor and make any adjustments to our position and movement, which essentially is your sensory-motor control. And to kind of get a value and appreciation of pain perception, it's always nice to kind of understand how our body perceives these kinds of pain that we're experiencing. So, whoops. There we go. So kind of the main objectives that I'm going to be kind of talking about, and this kind of reflected in this article, is we're going to be kind of summarizing the leading research on pain neuroscience that kind of helps assist our interpretation when pain indicates the need to stop stressing the tissues, or when it's reasonable to quote unquote dance through it. We're going to be talking about some research advances, like previous research, current research, and future research to help us understand the effect of pain on the control of posture, movement, and rehabilitation. And kind of at the end, we're going to just discuss like a small framework that's proposed to help translate and integrate this research evidence. So the problem with pain perception, the purpose of pain essentially is to tell us what's wrong. It's to tell our bodies that something's wrong with our body, to tell us about the damage, threat, or danger to tissues. Now the main thing with this is that there is an issue between sometimes what we perceive sensory-wise and that our body doesn't accurately reflect that. Our natural body just assumes that the sensory inputs that we get from the physical world, that we get from our body, that the brain perceives those inputs accurately to represent any stimulus. So that stimulus can include any mechanical stress, chemical, heat, cold exposure, any tissue damage. So there can be sometimes an imbalance with what our body perceives and what's actually happening. So they actually did a pretty cool study where they took a bunch of people, put them through really, really cold exposure There was some specific temperature. I don't remember off the top of my head what it was, but and they asked these patients or these participants of how they perceived pain. And as you can see across the 17 subjects, that they perceived pain very differently, with 0 being no pain at all and 10 being the worst possible pain you can feel. So this begs to differ, like how can pain perception be so variable with a highly controlled stimulus? Why is it that we perceive pain so differently from individual to individual when it essentially is the same damage that's happening to our body? And this comes down to peripheral versus central sensitization. So peripheral sensitization is perceived by the skin, the joints, bones, muscles, or any other soft tissues. And there are two types of fibers that can perceive this type of stimulus. You got your A delta fibers, which are sharp, well localized pain, and then you got your C fibers, which are dull, burning, or aching pain that you receive. So peripheral sensitization is essentially any processes, any stimulus that can cause us to distort or amplify detection and transmission of any threatening stimulus. So essentially, you get inflammation to any tissue. You get sensory stimulus to your nerves that are very highly adaptable, and they release these chemicals into the body, and that's how your body perceives this peripheral stimulus. And then essentially, these processes end up going to the spinal cord, which also get amplified and distorted even more to the brain. And that kind of leads us to our central sensitization. The brain is constantly updating and modifying its understanding of the body's response to stimulus. And there's a pretty cool theory that's out there. It's called sensory windup. It's where the spinal cord cells become so conditioned to multiply the amount and duration of danger or threat signals that are sent to the brain every time a signal comes in from the body. So it's, let's say you cut your finger 100 times, and it happens to hurt more every time. But as you start cutting it, as your body starts getting used to it, you think that it's not going to be painful, but your spinal cord and all the senses that are going to the body or the brain, they're increasingly multiplying the thrust signals that need to be sent to the brain to perceive this pain. So sometimes even a small injury can be sensitized to a point where your brain thinks it's something very, very serious. So if your brain essentially receives these distorted signals and the sensory windup, this inflamed injury might end up feeling massive, even though the injury has only increased slightly to you. And this paper actually talked about a really cool concept called the neural matrix, which is depicted through this image here. It's essentially what I kind of talked about is nothing can be interpreted until the brain processes incoming information. And it's called Melzak's neural matrix concept. Essentially, you're starting off with any sensory input: touch, sight, taste, smell, hearing. Or let me rephrase that. You can start with any of emotion, sensory inputs, or thoughts. And there's also a psychological aspect to it when you talk about the emotions, feelings, and thoughts of it. For me personally, I've had 2 ACL injuries. So obviously, the first time I had it, I didn't feel as, I was like, oh shoot, I knew something was wrong with my knee. But the second time I had it, I had this perceived memory in my head of just like, oh shoot, I don't want this happening again to me. I already knew what the struggle was of going through rehab, of what it took to kind of recover, to kind of get back to where I wanted to be physically. So this memory, this interpretation, this expectation of, shoot, I'm gonna hurt my knee again. I'm gonna avoid anything that involves hurting that knee. So you get these perceived concepts, these perceived thoughts, emotions, and feelings in your brain that essentially lead to how you perceive pain going forward, and how you get this plan of action to be taken. And there's definitely a stress hormone kind of balance to it when you do go through such injuries. And they're actually testing this through virtual reality, just seeing how athletes, they have this perceived conception of whether it's Achilles injury, ACL injury, injury to any lower extremity injury, or even their back injury. They have this perceived conception that, shoot, if it happens to me, it's gonna essentially suck. So they've done virtual reality studies with it where they kind of see how, if if they do get injured through virtual reality, how that kind of affects this neural matrix complex, how this multi-sensory input can kind of have effect on their body. And this is kind of how chronic pain is kind of managed, to kind of get a sense of how these patients think of how they're feeling through this chronic pain. But acute pain can also be treated this way or interpreted this way as well. So interpreting any amount of threat based on factors such as personality, memories of the past injuries, anticipating the impact of a new injury, which is huge among dancers and athletes, and the effects of these factors on anxiety and sensory input to the nerve endings of the spinal cord is essentially what this neural matrix is. So essentially what we can feel can change the brain's interpretation of the body and affect the control of posture and movement when you're training. So motor control and stability both describe two important aspects of movement behavior. Essentially, the object of a dancer is to perform a series of postures and movements involving the trunk and upper and lower extremity. That can be done individually or as part of a group, but you're essentially expected to perform under a variety of loads and contexts. For a dancer, movement behavior has to be controlled. If you don't have that motor control and stability, you end up with a lot of problems. And I'm going to use this example of low back pain, which is huge among dancers. You are expected to essentially manage variations in physical load, how much load you're having on your lower extremities, on your calves, on your hips, on your knees. As a dancer, I've danced for a long time, and I've been involved in the dance community for a while. So I've definitely felt the load in my knees. And if I don't have the proper training, if I don't recognize the symptoms that I have in my lower extremity, then that's just going to cause further damage and cause further injury to me. And you also want the mental complexity, having the right training environment, having the right people around you to train the way you need to, and the environment, the context of performances, whether it's a rehearsal, whether it's a practice, whether it's an actual performance. These are things that can have a huge impact on your injury context and injury perception. So if a dancer is able to maintain his or her pattern of behaviors in these given scenarios, in these important concepts, this is what you call stability. This is what you call good motor control. And essentially a system has to be either stable or not be stable. There's no kind of in between. It's kind of, a dancer has to kind of find that concept, or find that endpoint of, am I stable enough to train, perform, or am I not stable enough where I cannot further move on. Posture and pain. So there's been studies out there, there's been some theories out there that many thought that flexed spine posture is dangerous for the spine among dancers. They think it could cause increased fluid pressure within the spine discs, leading to degeneration. But what studies have shown that this alone does not predict spinal degeneration. This does not cause pain from the spinal cord when you are dancing. And I'm going to be kind of talking about, as we move on, that there's going to be two types of rehab specific or two training modalities that one can go through. You can either do general trunk muscle contraction, or you can go through specific trunk muscle contraction. And those are two very different things that I think they go hand in hand with each other. And these exercise approaches optimize robust control of spinal motion. And it's not just spinal motion, it can be shoulder motion, it can be knees, it can be Achilles, it can be calves, this can be kind of for anything. Muscle function and pain. So when we look at the systemic approach to stability, as I talked about a couple slides ago, we really have to be cautious about it, because the brain perceives there's so many different muscle strategies that we can do to complete a certain posture movement. There are so many muscles we can do to, kick a ball, or lift weights. For example, if you're doing a deadlift, there's so many different muscles you can use to engage a deadlift. But if you aren't engaging the right muscles for that deadlift, you can cause injury to your back. But your brain perceives it when you're in. Your brain essentially has a psychological effect that if the dancer completes the move without pain or injury, that they feel enabled, that they can continue using that same motion over and over again. And it's funny because some of these strategies have an advantage in terms of efficacy, effort. Aesthetics is huge in the dance community. If it looks good, the dancer will think, okay, I'm gonna keep continuing it this way when essentially isn't the right way to do things. Um, and sometimes, with me, I have even fallen in the trap of doing things a certain way to avoid joint stress, especially in the knees. Um, but using a specific posture, using a specific muscular strategy is not guaranteed a freedom of injury. And that's, as current physicians, as future physicians, residents, when you're talking to a patient, I think that's really important to tell them, like, just because it feels pain-free doesn't mean it's not going to cause any long-term effects to whatever you want to do in the future. Um, and this is where kind of understanding the neural matrix plays a huge role here. That although something feels vulnerable, distortion and amplification of sensory perception means that such feelings may not necessarily reflect the reality of the stability of those muscles. And it's kind of going back to low back pain example. Using your lumbar multifidus muscles. EMG studies have shown that deep fibers are not always active in all posture and movement tasks. When you're training, you get these muscles that are switching off in certain movements and certain postures that give us a false feeling that we're okay, that we can continue on with this certain movement. When in reality, it gives us this. It can cause high risk of injury in the long run. So if we have this anxiety provoking descriptions that contribute to fear or anxiety, all the efforts that we put in are going to be counterproductive for pain perception and movement control. So I'm going to be talking about some just like research paradigms, as I mentioned before, like the previous, current, and new ways of just perceiving pain and kind of helping dancers move through their training. The previous thoughts of how we perceive pain. There are two modalities. There's a vicious cycle theory where you contract muscles forcefully in areas of pain. Like if you hurt your calf, the muscles around it are going to really contract to kind of protect that area. Where in contrast to pain adaptation theory, the muscles will contract with less force, and you'll get kind of the opposite muscles to contract. So if you hurt your bicep won't contract, but your triceps will to contract to kind of protect that area. So you get the antagonist muscles contracting in the pain adaptation theory. There's the current theory right now is even if two people have the same sensory stimulus, each person's neural matrix is unique. And that's kind of the current way of perceiving things. When you're talking to different dancers, different athletes, you really have to keep in mind that this person's perceived thoughts, perceived emotions, perceived sensory stimulus is going to be different than dancer B or athlete B. So it's really important that as future physicians, that we keep that in mind, that not all dancers are going to be the same because they're going to perceive everything differently. And then there's this new theory or research coming out where pain and context factors change the way nerves coordinate contractions of the fibers. They change the way muscles are contracted during times of injury, and the timing and amplitude of the contraction of one muscle versus other. So it's essentially what I'm going to be talking about on this next slide here. It's this new theory for motor adaptation of pain. Even without injury or pain, we have this perceived preconception of risk or threat that can be enough to cause us this fear or this psychological effect of pain as a dancer. I'm going to use this example of my knee injury. After my first knee injury, I've had this perceived thought, this anxiety of fear of another knee injury. And this will change my sensitization of how my brain perceives any other injury I have from here on out. The muscles are going to react differently. So obviously when you injure your knee a second time, there might be different muscles that are contracted. There might be different muscles you're going to have to help relax, have to stretch, have to work out. And that's gonna have a huge impact on your posture and movement when you're dancing. I've danced on a torn ACL before. So dancing on a torn ACL, it throws off your whole balance. You have asymmetrical movements. You have you're limping, you're limited in your motion in the affected area, especially when you're doing squats or jumping, or anything in that regard. So it definitely throws off your hip balance, your pelvis balance, and everything, from top to bottom. So there are definitely positive short-term consequences versus negative long-term consequences of having this motor adaptation to pain. And you get this common phenomenon of stiffening of the affected body region, which is going to happen if you have the injury or if you don't. So if I'm in pain, should I train? That's the $1 billion question. You're gonna be asked 1 billion times, hey doc, can I do this? I feel fine. Why can't I do that? If they get cleared for a sport, if they get cleared for performance, cool, I can train. But how should I train? These are things that you're gonna be asked if you go into, pain, sports medicine. You can be asked as residents, when you're in clinics, you'll be asked this in any aspect of your career. And it's always important to kind of understand where or how they're perceiving pain. So hopefully, the next few slides I'm going to talk about how it can be, how you can apply this to clinical setting. So when you have pain at rest, when you have someone who has pain at rest with no mechanical stress, a combination of sensitization process may have occurred in the spinal cord and brain already. They might have already, it's the wrap up concept I was talking about earlier, where the spinal cord is just so accustomed to amplifying any sort of small stimulus, where just even at rest you're getting this pain. Essentially it's difficult to even know how meaningful these pain symptoms are then. If pain is felt with minimal stress to the body, then sometimes it's hard to perceive if, there may be no new injury, but some combination of peripheral and central sensitization may be maintaining the symptoms. It's really hard to grasp. And I think even with people I talk to, and even for me personally going through all this as a dancer, even I don't understand, if I'm sitting here having this knee pain, how do I tell if I can continue to train, continue to work out, continue to perform? It's hard to tell. And I think, having that understanding of what the neuromatrix is, and kind of having understanding of this goal of diminishing the sensitization of the nervous system. I think that's the key. I think that's the key principle to identifying the amount that an activity can be done before it causes a flare-up. So I think having that understanding, having that goal to desensitize your nervous system, that can prevent further flare-ups and kind of help you move forward with your training. And it's something I talked about previously. It's I think it's the next slide here. Yeah, rehab with specific and general techniques. I'm gonna continue with this example of low back pain here. You have this specific focus exercise program where it's techniques focused on the basics. Okay, these will help overcome changes in sensory and muscular function that have occurred with pain, to reduce adverse stress to tissues. So if let's say you're dancing, you're doing certain ballet movements, okay, ballet is something that's very intricate, has a lot of lower extremity injuries. So if you aren't doing certain techniques of ballet correctly, if you aren't doing the basics right, then you kind of have to go back to the very specific, techniques, the basics. When you're teaching, I used to coach dancing. I used to be part of, and it's whenever something feels wrong, whenever they're having pain, I'm always like, okay, let's take a step back, let's focus on what you're doing wrong, because obviously something with the basics isn't correct. So it's always about taking them a step back to basics. And if they're running, sometimes you just have to relearn how to run properly. If you're having low back pain, if you're having knee pain, if you really have to learn how to reload your lower extremity to run the proper way again. And then you have this general exercise program where you focus on strength, power, endurance, flexibility. This is more patient-centered. This is more or patient focus, where they're kind of doing it independently, where you give them progressive challenges with dance skills that can increase tissue robustness. You have them hit the weight room. You have them focus on power. You have them work on stamina. You will have them stretch, do yoga. Those are very general. Those are very general exercises that patient can do on their own. So when you're looking at the example of low back pain, you have this, the one paradigm is focusing on specific muscles such as the transversus abdominis and lumbar multifidi muscles. And then you have the other paradigm, which focuses on more general exercises such as cardiovascular fitness, strength, flexibility. So I think essentially what my point is, the specific muscle rehab, along with a combination of the patient-led general approaches, led to similar overall effects to improve patients' pain perception and ability to perform. And that goes back to essentially desensitizing a patient's perception to pain, desensitizing how their spinal cord and their brain is perceiving these pain stimuli. So, dancing through it. Should you do it? Should you not? It's funny because doctors always make the worst patients. If you ask me, I am probably the worst person to ask. Outside of, if you ask me as a friend, as someone who danced on a torn ACL, I might give you a different opinion than if you ask me as your physician. It's crazy that we all have these different experiences, but when we're put in a professional setting with a patient, you give them the advice that you need to give them, okay, and not what they want to hear, unfortunately. So it's this, if you have mild moderate pain that only occurs during a challenging activity of the body part, there's this conception that, okay, you may continue it. Continuing activity may be an option, but the ability to continue doing the activity over time, like over weeks, then from days to weeks to months, if you're not having as much pain as you progress through timeline, that may suggest that there's been little or no progression to tissue injury on each occasion. So, the more load you put on your knees, the more load you put on your back, if you're not having as much pain or no increase in pain throughout a time period, then that just shows that there's been no progression of tissue injury. These pain symptoms that people have, they essentially represent a sensitization of the nervous system acting as an early warning before injury has occurred. So, it's as a dancer, I was like, something just feels off. Something just feels off with my lower extremity, my back, my neck. This is essentially a warning sign that your body region is being overstressed. And then essentially this could suffer more rapid degeneration than normal. And this is where I was kind of talking about. It's the both specific and general exercise approaches could be a benefit. And that's where you kind of have to sit down with your patient and just be like, okay, we're going to focus on specific aspects of your training regimen. And then we're going to focus on general exercises that you can do to kind of get you back to where you want to be. So, as you guys kind of assume by now, there's lots of challenges to this. There's exercise has to offer sufficient challenge to result in adaptation and improved control. You want to have the ideal exercise regimen for a dancer to kind of get back to the performance level they want to be in. So it would seem ideal for the exercise to feature appropriate levels of load, task complexity, and features of context. So I'll be talking about this in the next few slides here. So load. This is essentially, it means it can arise from the force generated by muscle contraction or from a muscle applied to the individual. So load is essentially how much pressure you're putting on a specific area of your body. And this should be adjusted so that there's sufficient stress to cause adaptation that will improve integrity of that tissue or the muscle. So if you have, an injury to, say, your calf or your Achilles or something like that, you strained a muscle, that you're a ballerina or you're involved in ballet, you have to work slowly but surely to get that increased load onto it. You don't want to start putting full weight on your calf or Achilles right away. You want to start slowly increasing the load, whether it be with body weight or with actual weights in the weight room. You always have to be careful that too much load can result in a flare-up of your pain perception, or essentially can cause further injury to your tissues. So load is always something that I have always, when I've been dancing or coaching my dancers, it's always like, okay, we figured out your basics, we figured out what's wrong. Let's start off slow. Let's start off slow of what we can do to start loading this specific area of your body. I don't want you doing, 30 jump squats right away. I don't want you doing, just 40 lunges or anything like that right away. I want you to slowly increase that load on your body so that when you're doing like an 8-minute routine or however long your routine is, that you're able to handle that constant load on your lower extremities. Task complexity. So this is the number of criteria that are associated with successful performance of the exercise. So an example is, just an example given in the paper is being able to maintain postural load to one region of the body while coordinating balance or movement at another region. Just a simple example I always give is if you ever have those balance balls that you use, you're balancing it on with one leg and someone's throwing a tennis ball at you. This is task complexity. It's where your brain is getting used to different stimuli occurring at once. So it's dance is not linear. Dance is not linear. There are different movements, different parts to it, different expressions to it. So getting a dancer, getting used to slowly building it up to, okay, we're gonna start with one aspect of the dance routine. Now let's build it up to 2. Let's build it up to 3 aspects. Now let's do it back to back to back. Let's do it. We're just building stamina, and you have to kind of get that brain used to being in a vulnerable, in a vulnerable state of mind where you aren't worrying about pain perception at that point. So it's all about desensitization. It's desensitizing the nervous system. And then the context. This brings in a psychological component of a performance. Pain is not just like ouch. Pain is not just ouch. Is the best way I could put it. Pain is also the psychological component of how someone perceives pain. So if a patient, there are lots of people out there who rely on pain medications, who rely on trying to control this pain when essentially there's this huge psychological component to it, and that relays onto dancers as well. So the context of a dance environment is any environmental conditions in which the exercise is performed, whether it be you practicing in your basement, whether it be you practicing in front of a coach or with your teammates, or you practicing as a dress rehearsal, just increasing the context to kind of make it mimic the actual performance is a huge psychological can be a huge psychological benefit to the dancer itself. So load, task complexity, and context are the 3 huge things you really want to talk to a dancer about how to train back into their performance, into their routine. So kind of the main summary of this article is with improved understanding of the pain neuromatrix and motor control, it's hoped that we can essentially make a framework that can be applied to a wide range of exercises and rehab models. It's like I said, it's not just for dancers. It can be anyone who is trying to get into physical shape, any athletes you're working with, whether at any level, high school, college, professional, it can be anything. It's really just trying to desensitize your nervous system, trying to get the patient perceiving pain differently and trying to help them build that confidence, get used to that load, so their brain can kind of adapt to how their body used to be. And this framework can essentially form the selection and application of exercises, whether it be through a specific exercise regimen or a general exercise regimen, to help the current nervous system sensitivity and tissue integrity, so that sensory motor control is able to control the posture and movement under a broad set of conditions. So this is just an interesting way of just kind of perceiving how pain can be dealt with in dancers. It's always hard to tell a dancer what they don't want to hear, but if you kind of understand what is causing their pain and how you can kind of create this specific load, task complexity, and context regimen for them, I think that'll definitely help them become the best dancer they can be. So that's essentially my article, guys. I put my email address down there. If you guys have any questions about PM&R, about MCW in general, I'm always available via email to help. So yeah, thank you guys.
Thank you so much, Dr. Singh. Awesome presentation. We actually did have a few questions from our sign up link that we had. Okay, if I ask you some of those?
Yeah, go ahead.
Awesome. With regards to the article, somebody asked, how useful is using a pain scale, especially with athletes, even more specifically dancers who often have a self-reported higher pain tolerance secondary to their training?
Yeah, no, that's definitely a good question, and that kind of comes down to of what, once you start getting to know the athlete and dancer more, you kind of get an idea of what their baseline level of pain is. I think when you first meet an athlete, first meet a dancer, and you ask them, okay, what's your what's your pain of 0 to 10? That's you'll probably get like they could have a serious injury and they're like it's probably just a 4. But I think helping the athlete, helping the dancer understand, like, hey, I personally think this is a more serious injury. If your pain level's at a 4 right now, I want you to understand that usually people have higher pain scores to the specific injury. I personally don't think that should change how you approach your exercise plan, or how you approach to kind of getting them back into the shape they want to be. Now, you might have to, they might try to explain it. They might have a higher load impact when they're first trying to train to get back into things. They might require a higher task complexity when you're trying to set up a training regimen for them. So I think it's kind of just understanding what they understand is the most severe pain, and understanding you as a physician, that they might excel in certain areas of a training regimen compared to other people that don't have this high intensity training, that this high intensity physical stamina that these dancers and athletes have. So hopefully that answered the question.
Definitely. I think it was a great explanation. I think it definitely helps shed some light on the topic for sure. Another question, these questions are kind of asking about your experience. Somebody asked, what got you interested in the field of PM&R?
So me specifically, I was between neurology and PM&R for a long time. But essentially I chose PM&R kind of just because of the wide array of things you can do in the field. I didn't know what to do exactly. I was always interested in sports medicine. I was always interested in pain. I was always interested in stroke as well. I think stroke and TBI are two things that I was kind of leaning me towards neurology. But I think essentially with kind of my background of just kind of the injuries I've been through, of just kind of helping patients understand of where they are right now, and essentially where they can be. I think that's a huge thing that you really can't get in other specialties. So I think as a physiatrist, you can definitely be there along each step of the way with a patient and trying to get them to get back to their, as close as possible to their normal way of life. So for me personally, I'm interested in pain medicine. That's kind of my main area of interest. But I also want to implement the psychological aspect of pain, as well as kind of getting the sports medicine and the dancer aspect of pain as well into hopefully my future career. So that's kind of what brought me into PM&R, and just because you can do so much with it.
So cool. So awesome. People are asking, how can medical students get involved in performing arts medicine?
Oh, that is a good question. So I definitely know that just from my personal experience, a lot, if you're near like a big university or big college, those big universities. I went to University of Wisconsin, and there were so many dancing. Performance arts was a huge thing at University of Wisconsin. There was always so many ways to get involved. Even if you yourself wasn't a dancer, you could always get involved in kind of helping whether it just be through injuries or just kind of helping just be a source for people. I know for dance competitions I went to, there's always, especially recently, there are always people kind of on the sidelines, available as volunteers, if there were any injuries that happened during the competition, or if people needed just any advice or just anything to kind of help them if they're having any acute injuries or problems or aches or anything. I think that's always a good way to just kind of reach out to any university you're nearby, just kind of like, hey, I'm just a medical student. I'm really interested in kind of just, being a part or just kind of observing how you guys, go through performance arts. And I'm always available for any injury questions or anything like that. And just kind of just putting yourself out there is always super helpful. And there are always going to be people that reply, because as dancers are always going to get hurt. That's just kind of the sad reality of it. There's always going to be aches and bruises and pains. So I think just kind of reaching out, just kind of introducing yourself, and just kind of just letting them know that you're available, because sometimes these performance arts teams, they don't have the resources to have, physical therapist there, or like a team physician or anything like that there. So it's always nice to kind of just put yourself out there, just be available for these performance arts teams that are out there.
Awesome. Thank you so much, Dr. Singh. Does anybody else have any questions about PM&R, about the article that we read?
Hi. So yeah, thank you so much for this. This was really cool. I'm Urja, and my question is, so you talked about the diminishing sensitization with repeat injuries, right? And how that with repeat injuries, there's going to be sensitization and increased pain response. So have you heard of or had any experience with patients undergoing neuromodulation through non-invasive brain stimulation, specifically for chronic pain?
Mm-hmm. Ooh, that is a good idea. Good question. I don't have a lot of firsthand experience with it, but I have heard that that is a good way of just kind of controlling chronic pain. It's usually not something that's common amongst dancers per se. That's kind of just because they're younger, they're more adaptable, they're more friable, I guess. Their sensory and motor complexes are more friable, that you're able to kind of desensitize things. So that's not really a common thing amongst younger dancers and athletes. I think that's kind of more common as you get into older populations, kind of more with Broadway dancers, I think, from what I know. Those people that are much older, that have been dancing, that have been training literally their whole life to kind of perform at these big stages, these big shows. The neuromodulation is a huge thing for them. That I do know. I don't have, like I said, I don't have too much experience with that. But I know that's a huge aspect in Broadway dancers specifically.
Okay, cool. Thank you.
Yeah.
Hey, I was just wondering, with the desensitization process, in your experience, how long does that usually take to get a patient back? And is there any difference between the timeline of the load, the environment, and the complexity, or do they usually all kind of go together?
Yeah. So from my experience, I think it's very patient to patient. It's definitely not a linear thing for each person. The way I look at it is I personally don't feel comfortable having a dancer go back and competing or performing until they're comfortable at each load, task, complexity, and context. A dancer can be completely, comfortable in kind of the context of their situation, but they might not be fully there with a load or task complexity. So each of those three things are not always linear. I think for me personally, it just depends on what the dancer's priorities are. If there's a psychological aspect that you're seeing with a dancer, then maybe context is something that you really want to focus on. If strength or stamina or endurance is something that you're seeing in a dancer that they really need to work on, maybe load is kind of the majority that you want to focus on when you're creating this return to dance program for them. So I think that's a good thing to point out. That's not going to be the same for each dancer or athlete. It might not be in a week. It might not be, you know, in the next month or so. It might sometimes take a long time. And you hear these athletes, you know, these athletes that are still continuing to have pain in their joints, you know, even after surgeries, and they're requiring even more surgeries to help with that pain. When in reality, maybe just desensitizing that athlete or dancer to that specific pain they're having can actually probably help them get back into form. So sometimes, you know, I think for us, you know, since we're like kind of the non-surgical, you know, sports medicine people, that sometimes surgery is not always the answer. You know, jumping to surgery is not always a thing. Maybe we have to try other things before, you know, doing other invasive procedures. So.
Thanks.
Oh, I think you're talking, but I can't hear you.
Can you hear me now?
Yes.
Oh, perfect. I was saying I'm definitely not a dancer, but this has increased my appreciation for dancers in itself. So my question was kind of during, I guess, where in your discussion or treatment do you start talking about going back to the basics? Because as someone who's played like sports for a while, like my whole life, it's kind of like if someone told me to go back to the basics, it's kind of like, ah, no, you're crazy, you know, like so where during that time do you tell them, hey, like we should start considering going back?
Yeah, no, definitely. I think so. I'm just gonna throw a random example out there, like throwing a baseball. Like if you're a pitcher, okay, it's you know, with this high incidence of just like Tommy John surgeries that are going out there, that are happening right now. Some, you know, I'm not saying they can be preventable because, you know, with these athletes that are starting to throw at younger ages, they're starting to throw at faster fastballs, I guess, at younger ages. You know, it's weird because now they're like saying that these younger athletes are doing preventative Tommy John surgery now, which is weird, just so they don't have like, you know, complications in the future. They just get it over with once, they don't have to do it again. But I think once you start noticing kind of a change in their motor pattern, you know, once you start kind of realizing like, okay, he's throwing the ball a little differently now. Sure, he's not having pain with it, but let's take a step back and just trying to see like, okay, you're pitching the ball this way. Why are you doing it this way? It's kind of, it can be kind of preventative, but unfortunately people don't, you know, go back to basics until someone starts feeling the pain. That's just kind of the reality of situations. Cause you know, it's like, we're trained as athletes, like, you know, if it's not painful, just keep doing it. So I think pitching a baseball is probably the best example, or being quarterback, throwing a football. It's, you know, there's so many quarterbacks out there right now that are training in the summer and training during the summer. And they're like, you hear like an ESPN talking about, you know, these quarterbacks are training with quarterback coaches and revamping their basics, revamping their fundamentals, because you have all these players that are having shoulder pain, elbow pain. And it's like, okay, you're having all this pain. Let's take a step back and like try to polish up your basics here. So it's these people that have been doing it a certain way their whole lives, and they just don't catch it until they have pain. And you know, we won't catch it until they have pain either, as their physicians. So.
Thank you.
Yep.
I have another question. So you talked about the non-linear aspect of desensitizing, right? So the load, the complexity, the context. Would dancers, let's say in terms of the context, would dancers with a history of mental health issues, let's say like anxiety or a history of trauma, possibly take longer to desensitize from an injury because of that, and just like the increased like cortisol levels that they have at baseline?
Yeah, no, that's definitely a good point. There were some I didn't touch on it too much in my presentation, but I think the mental health aspect of a dancer is definitely a huge part of getting back into dancing. There were definitely some mention about anxiety-induced fears that can change the chemical processes that are perceived to the brain. I think for that, the context is a huge aspect of it. And that's just kind of getting to know your dancer at kind of a personal level, just trying to see, okay, why do you have anxiety? Why do you have performance anxiety? Why is it when you get that you can perform when no one is in the room, but when you get out there on stage, why is it that you just kind of falter? And I think that's, I think that's where kind of the multidisciplinary team kind of comes in. I'm sure there will be other other people that are kind of monitoring the dancer as well. But I think, understanding the psychological aspect of it is definitely huge. I think, depression can also play a huge factor as well. I think that's something that's not touched on as well amongst dancers, or just any athlete in general. It's where you hear these people that just aren't mentally ready to get back into performing, or because there are always these high expectations. We as dancers or athletes, we're always ingrained like we have to do this or else we are failures. And that's just reality of it. That's just how we are ingrained. So I think understanding your dancer at a personal level, trying to understand what is it that they can do mentally differently. And sometimes we as physiatrists don't have the answer. Sometimes we need to get other people involved as well, like psychologists, psychiatrists. If there's some sort of trauma that's been kind of involved through their dance experience, I think that's definitely a huge aspect. I think that's not been touched on enough in the community. So I think that's a good point. They definitely mentioned a little bit of anxiety stuff in the paper, but I didn't touch too much on that.
Awesome, thank you.
You guys, great turnout tonight. Dr. Singh, thank you again so much. This was so awesome.
No, thank you guys. I appreciate having me. It's my first time doing something like this, so I had a lot of fun making this presentation. So, but yeah, if you guys have any questions or anything, I put my email down. More than happy to talk over email. And if you guys have any questions about the application process or anything like that, I'm always available. I'm better over email than text, so email is the best way, just because I feel obligated to answer an email. So yeah, thank you guys. Really appreciate it. This was a lot of fun.